to introduce our amazing moderator, Tim Bressman. He is an associate professor in the Department of Speech-Language Pathology at the University of Toronto. His research focuses on the diagnosis and treatment of oral nasal balance and articulation orders in individuals with cleft lip and palate. Everyone, Tim Bressman.
So the goal of this roundtable is to explore how speech therapy has been redefined in the COVID area, with speech professionals forced to work in new and innovative ways. In this roundtable, participants will explore safe and promising approaches to virtual and in-person speech therapy, including online tools, parent engagement, and oh, my notes are gone.
Here, I think we should be back.
It's a bit embarrassing because I didn't learn it by heart. So much for my amazing hosting. In virtual and in-person speech therapy, including online tools, parent engagement, and lessons learned. So as they say, a crisis is a terrible thing to waste. And while we face many challenges related to COVID-19 and the changes that we have to make to our practice and to how students are taught, patients are seen, it also gives us an opportunity to do things differently and maybe make a few things better here and there. So the next slide, please. Let's go straight to our presentations. And our first presenter is going to be Lakshmi Godavarti from Visakhapatnam. She's the project head for speech and communication disorders and comprehensive cleft palate care at the ABMSS, which is a charity that was formed relatively recently in India, but that has expanded very quickly and now supports 36 cleft centers across different parts of India. She's also the founder of the Visakha Speech and Hearing Center in her hometown of Visakhapatnam. And in addition to cleft palate, she also works in other areas of speech pathology, such as myofunctional therapy, autism, CI, so cochlear implants, aphasia, dysphagia, sleep apnea, and other speech-related disorders. So we're looking forward to your presentation, Lakshmi.
And I love the way you pronounced Visakhapatnam properly. Thank you so much. Hi, all the delegates. Here I am. I would like to present on temporary replacements of conventional therapy to teletherapy. I'm G. Sri Lakshmi, MASLP, Head of Speech Centers. Next slide. Yeah, okay. Lockdown, yes, has given a lot of challenges. Challenges were not new for both professional and personal lifestyle of ours. But this challenge has been different. It didn't give much time to us to prepare. And not only professional challenges, we had to face the personal challenges also at the same time. And not only in one place, all over the world, it has happened the same way. Usually speech therapists are used to using a lot of body language and trying to understand the person in person and directly. But now our hands are tied and we are just stiff right in front of the screen, shortened. Next, the first challenge we faced was, next. Children attention. We didn't understand, like, how can a child sit in front of the screen or a small mobile phone for a long time and understand what we are going to say. And the problem actually arose when we started avoiding gadgets to the children. And we always encouraged them to say hi-fi. Whenever they do some good thing, hi-fi directly. And we also used very less toys. And we also encouraged them to play with us rather than using a lot of soft toys and things like that. But yes, this sustained. Children avoided. But over the period of time, they understood and they stayed stable. And we adjusted different things, like we have started using different attires, like putting a cap like this and using toys like this. And we also started using torches to put it on our eyes so that the child will be like seeing like what is happening in the screen. So this helped us to gain the attention of the children. Next slide, please. The second challenge we had faced was, next slide. Therapy material. We always used standard material because we wanted to know if we can present a paper on it. So the standard materials we used was like ballovens and face warmers and even those U-trainers which the musicians use. Sir, can you put the previous slide, because this is another one. Therapy materials. Yeah, thank you so much. Sorry for this. And we selected different materials according to the problem. For example, lip problem, they had to use ballovens. For teeth problem, they had to use face warmers. And we also had to use speech and language material customized according to the child's language capacities. But now everything has changed. We had to use household articles and kitchen materials like spoons and roti dough and things like that. Children could accept them very easily because they see those things regularly. Speech and language materials, whatever we could design according to the child, we had to text them onto their WhatsApp. They could see the text and repeat the words simultaneously when we're giving therapy online. So we could come out of this challenge also easily because of the technology. Next slide, sir. It was very difficult to make them understand how to face the camera or how to place their phones in front. Phones and cameras were used only for selfies or taking pictures. Video calls with friends and families were always informal. They didn't know how to make the background and how to see the light and things like that. Clarity of the video and the placement of the phone were not practiced regularly. But the major problem, what they used to ask us was, should they see themselves clearly on the second camera or the therapist face clearly? And phone was always kept in the hand, and they used to cover the face, cover the light with their face looking at the camera. So this was our major challenge, like how you can see it in the picture. I can see only the shadow of the face. There's no patient around. So we had to explain them to sit opposite to the light and try listen to us, then trying to see us. Next slide, sir. And the next challenge we had to face was the voice clarity. We always used to subjective listening, that is directly listening to the person, and then we could judge hypernasality or hyponasality. And voice clarity always differed with the word level, sentence level, and speech conversations. And our techniques were also dependent on the severity of the voice problems. How did we come out of this challenge was, we requested them to record their voice and send them as a sample on WhatsApp. And we had to listen to those voice samples multiple times so that we get used to that electric voice and then judge their voice. And we could guess the improvement from the first voice sample to the third or the fourth voice sample. And we didn't just guess them, we also could confirm the improvement from the attendee in their family. And the other challenge we faced majorly was, sir, next slide, the understanding. Many patients could not understand what the problem was, and how we were explaining the exercises on the phone, they couldn't understand. We'll wait for the slide. So next slide. I think that's the last one. The posture correction. We used to make the child sit properly in front of us, eye to eye contact, and make them listen to us properly. And we used to use minimal to maximum movement of the jaw depending on our visual, okay, place of articulation. How do we do it? maximum movement of the jaw, and the tongue placement. Amount of exposure applied to reduce the scar. We used to do exercises like this, touch the skin and reduce the scar. But what happened to all these techniques? Many of the time, parents used to use cushion beds. They used to put the child on the bed and on the video, and then the child will be on the bed. And they used to say that, okay, he's hanging on their arms and the video is in another arm. And this was difficult. We told them at least put them on the floor and just give them the support. So this helped them. And then the jaw movements, we make them use the spoon itself and give a small movement and see if the child is restricting, then fine. Otherwise, you can go a little down. So if you see these photos, one child could open only a little bit. And how can we expect them to raise their tongue up? Another child is over exaggerating. It might pain her after some time if she does it multiple times. So these were the challenges we faced, but mothers helped us a lot. And we also asked the mothers to apply a little oil so that they don't need to put extra pressure. If at all they put extra pressure, the oil can slip away and the scar is safe. So these were the many challenges we had to face and think over and try to solve them. And not only these challenges from network problem to family non-cooperation, they don't want to open the net for speech therapy. And they don't have time for speech therapy on the net. They'll come back only at 6:30 or 7:30 in the night. So these were the problems, but we could solve all these problems. And we are also well equipped to understand more challenges. And because we don't know when these challenges will be over, it could be days or months or hopefully not a year. But we are ready to work hard to show the progress of these children with cleft lip and palate. But everything was going around with technology. So thank you, technology. Thank you, sir. Last slide.
So I had muted myself. Thank you so much, Lakshmi. Like in previous presentations, please feel free to use the little reaction button at the bottom to indicate your applause or to indicate your approval of the presentation. So the way that we're going to proceed through this session is we're going to have all three presentations in a row. The presentations by Mirta and by Nana are pre-recorded, and then we will have a joint discussion at the end. But if you already have questions, feel free to start putting them into the chat, and then we will try and we'll try to make sure that we address every question that is asked. So our next panelist is Mirta Palomares, who is a speech pathologist and the coordinator of the speech unit at the Fundación Ganz at Luis Calvo Macana Children's Hospital in Santiago in Chile. Mirta teaches at several Chilean universities on the subject of speech development and on cleft palate, and she's a member of Smile Train's South American Advisory Board. She's also the author of several published articles about speech disorders, about VPI, and about 22q11 microdeletion syndrome, and has served as a reviewer for the International Journal of Otolaryngology. So Mirta, whenever you're ready, or when Ariana, whenever your presentation is ready.
Thank you for the opportunity to share how in Chile we are ensuring access to care to children with cleft lip and palate during COVID-19 pandemic. For many practitioners, face-to-face care is irreplaceable, especially for my generation, but any sudden change in life gives us the opportunity to assess and adjust our effort that will allow us to move forward and reach success in present and future situations. In my experience, change in the modality of care and how available resources are used could bring positive outcomes for those families in disadvantage due to their location from big centers of care, lack of access to innovative rehabilitation techniques and materials. Add to the above a much greater involvement of parents with the treatment of their children. What is the challenge? A total revamp of the way of providing rehabilitation care to families with children from newborns to 18 years old. I mean the whole age spectrum. What are the strengths? I am lucky to be a member in two highly capable and solid multidisciplinary teams. One is Hospital Calvo Maquena and the other one is Fundación GANS. What are the key factors of success? Diversity of the team members, age and skills, and a culture of collaborative approach without compromising autonomy of each of the members while delivering care. But how to start? Step 1, brainstorming to find options based in two elements of consideration: use of minimal resources and quickly implementation. Step 2, explore financial support through our donors network. Step 3, once finance secure, content development while working from home in a coordinated effort among team members. Step 4, return to step 1 to evaluate results and put new ideas and adjust current options to reach expected outcomes. Because most of families in care use a smartphone as a main device, any content needed to consider mobile and desktop access. To keep effective teamwork, we set a shared online storage and regular Zoom meetings were scheduled. Videos were developed at home, edited by one team member in high-quality format, and uploaded to our YouTube channel, where parents have access to see them or download them. The Parents Information Guide from children under 2 years, developed in hard copy, was digitalized and adjusts the format for distribution as mobile app. Finally, training to parents has been a key element to continue their children's treatment. This is the info to access the guide. Just move your phone close to the screen, open your camera, and focus on the QR code. Scan it, and you will have access to the document. As I mentioned before, all videos are part of a comprehensive library. There are two types of videos: for parents and/or therapists with instruction about their use, and a set of videos especially for children. The videos for therapists provide information about how to carry out assessment of phonoarticulatory organs, assessment of speech, and perceptual assessment of BPI. You can bring your phone closer and scan the QR code. In the first picture on the slide, you are seeing a video for children. The one below is for parents or therapists. It is key for adults to watch the video and the introduction to the new phoneme or sound, since this is the way they will be responsible to practice the content and the correct use. Keeping good metrics is a way to monitor our performance. Since March, a total of 3,500 views has been registered and 1,491 in the last days. User age is 25 to 34 and 90% are women. Most popular videos are for S and P phonemes and the explanation of compensatory articulation. So far, users from Chile, Ecuador, Peru, Argentina, Mexico, El Salvador, Colombia, and Guatemala have accessed our content. And much more information that drive us to guide our future innovation projects. In July, we share our content with speech therapists from Latin America. One positive outcome is training workshops for parents have increased attendance that when the sessions were presential. And the workshops are recorded and uploaded to our YouTube page, so they are available for families. In the near future, our goal is to design our own audiovisual media so that children and their families can continue working from home. We couldn't face this challenge alone, and I want to express my gratitude for the determined support of Smile Train and the committed effort from the team to keep a highly quality care for patients and their families. Thank you.
Thank you so much, Mirta. That was absolutely wonderful, very well prepared and very nicely presented, and definitely food for thought for the discussion, which again, we're going to have later after the final presentation. But is there something that you would like to add in person, Mirta? I'm just putting you on the spot here, I guess. So we'll come back to this later. And we have our final presentation by Ms. Nana Akwa Owusu, who hails from Accra in Ghana, where she's a speech language therapist and a pioneering supporter in the development of the speech profession in Ghana and in West Africa. She's the coordinator of the University of Ghana's new MSc program and oversees an NGO for children with communication disabilities called Awawaz 2. Nana Akwa also co-manages the Speech and Hearing Center, which is a Smile Train partner center offering speech support and counseling to cleft clients. Nana, are you online right now? Would you like to say anything? Yeah. Otherwise, we'll yes.
Yeah.
Okay, we can hear that your internet isn't going so well, so we will go directly to the recording, and then hopefully there will be better connectivity for the discussion. Thank you for joining us. So here's Nana's presentation on cleft palate care and COVID-19.
Hello, everybody. This is Manekia, and it's nice to be here. Thanks to the organizers for inviting me to be part of this. Now, I'm going to talk about speech and language therapy in Ghana during COVID. And I shall be making reference to Speech and Hearing Center, which partners with Smile Train. We get grants to support people who have had cleft clients who need speech therapy. And I'll also be talking about other centers. So Speech and Hearing Center is in Accra, and at the Accra, which is also in West Africa, Ghana and West Africa. So pre-COVID times, the therapists were more in control of sessions. We had booths, and we would invite clients to come to our venue. The time, the tools, and everything was actually decided by the therapist. And so the clients had to go by what we actually offered them. And so the control was more on the side of the therapist. And some of the challenges that we had included, distances that clients had to travel was one of the main difficulties or challenges. So clients had to travel long distances, and sometimes appointments were cancelled, or the people turned up very, very late, which affected the day. And so those are some of the challenges that we had before. So you can see in the picture, we had groups for children, group, and then we had parents meeting at the same time. So Next slide, please. During the lockdown, nothing was happening, not much was happening at all. We had limited phone calls to check up on families we knew had real issues with their children. WhatsApp platforms, there are a few WhatsApp platforms that were still operating or happening, and then we had parents exchanging information and supporting each other. And sometimes, you know, professionals will also be there to your help. We lost staff, and then there was loss of income. So for this organization, our 2 is an organization supporting children with speech and language difficulties. We came up with some new ways of supporting families. And this included coaching parents online to work with their children, offering them home therapy, which meant that we had to go to their homes, and also offering them the opportunity to bring the child to the center. So we could only see one child at a time. That's the next slide, please. We could only see one child at a time. So it was teletherapy, bring the child to the center, go to the home, and then telephone calls were really very limited, trying to find out, you know, how they were doing at home for those who didn't respond. So you can see in the picture that this one of our staff quickly took up the teletherapy option, and she's our main person who offers teletherapy right now. People can go home or come to the center. And more families are working from home now, more moms are working from home, so people seem to be requesting for home therapy. And I think because of the COVID too, somehow people felt that it was safer for them to be at home, so just one person coming in. It was easier for them than to be traveling to the center. Other times, people will come to the center in their own cars, so just to the center and then straight back home, and limiting interaction on public transport so that they were reducing the risk of getting infected. And WhatsApp groups continued, and we also had to develop COVID protocols for going to the home and then coming to the center. Next slide, please. So some of the challenges that have come up since this new way of working has included training. We really didn't have the opportunity or to be able to train anybody to do the teletherapy. We had to just try it out and do it ourselves. So we did the Zooms, we met as a team, and then we just zoomed in and out, just talking to each other and working it out. And one person seemed to get it, so she is the person who is helping with the Zoom, and we are advising and picking up information all the time to top up their skills. Cost of data is extremely expensive. Unstable internet is just the order of the day. Commitment sometimes is difficult. So sometimes parents will say they committed, but when the time comes, you call and they're not ready. The factory time for online is also takes up a lot of time. Even though we don't have many people who've taken up that option, it takes up a lot of time. And demo sessions that have to happen before. The fear of COVID also meant that majority of people did not respond to our offer to help or the different options that we had available. Next slide, please. Positive outcomes, more parent involvement. So now parents are more involved. A lot of moms, in fact, we've had some dads involved as well. Working with the child at home or from home or being coached online. Also now they tell us the times they want. For example, we had a parent who wanted afternoon at 2 o'clock. We wanted morning, and nothing will shift that. So there's a lot more power sharing, or we are managing together. Creative sessions, we both have to be very creative for the sessions that we're having. And especially if we have to go home, we can't always carry things home. So we need parents to be able to find things that we can use when we go home. And so there's a lot of talking, lots of sharing, and lots of creating the materials that we can use when we go. We have to be very flexible. We've learned to be very flexible. Travel time is now more or less like it's for both will be like same, because now in terms of cost, because now we have the therapist is likely to go home to the family, and so the cost has shifted a little bit to the therapist side. And also parents don't have to pay so much. And if it's online, you don't have to pay anything at all. And if it's at your home too, you don't have to pay anything. So new skills, we are all developing new skills. The therapists as well as the families are developing new skills, and we've learned that we need to be really adaptable in these times. And so some of the key points or key lessons that we've learned. If you move to the next slide, please. Yeah, before that, very quickly, we did a little survey of some of the organizations and found about 20 families we are serving. One family opted for online. Then 2 families wanted to bring their children to the center. Another 2 wanted us to go home. The rest of 15 have not responded, so we don't know what's actually happening with them and the children at home. Center B had about 20 children as well. Only 6 families responded and are bringing their children to the center for help. And the rest of the 15 or so are also at home, we don't know. Center C is a little bit more of an affluent center, I describe it as such. And about 7 families wanted online, 1 family wanted therapy at the center, and the rest of the families, 12, have not responded at all. So quite a significant number of families are still not opted for anything. So we don't really know how the children are being supported at home. Next slide, please. And then we did one for the CLEP clients that we had, because we had just finished a session with them when the COVID started, and wanted to know how we'd be able to follow up. And so we wanted to find out about smartphones. We called, and quite a significant number didn't have smartphones to start with. And those that did, because 1% that did, not all of them were very good with Zoom and all the new ways of working. About 28% did not really respond or haven't responded yet. And a handful of them, about 4 or 5, said they wanted discharge for their children were doing okay anyway. So quite a significant number don't have smartphones to start with. And so it would be difficult to be able to do anything online with them at the moment anyway. Next slide, please. So some of the learning points include, or the key points that we learned include that there's going to be more, I feel there's going to be more therapy at home. People are going to request for therapy at home versus the center. So either at home or they will come to the center. There's going to be shifting of roles between the therapist and the parents. We're going to need training for both staff and parents, for infection control, for also teletherapy, and for new ways of working, and maybe other new ways of working. And the new and the old forms are going to go alongside each other, because they have people who are like middle classes, and those who have the smartphones are likely to be those who have the smartphones. They are going to request more maybe for the online, whilst those who don't have are still going to either come to the center or request that we go to their homes. And that's going to be also challenging, because for those who don't have, they may not also have the space at home for us to go there. So they may have to come to the center, which means that the cost will continue to be the same for them. And then we have to think very carefully about infection control when we go into people's homes, the toys we use, the resources, how we disinfect them, those that we use that will stay in the homes, and those that we take in and bring out again and maybe put to use in some other places. So we really need to think about all these things, and not just about, I think this is also raised an awareness about infection control in general, not just about COVID control, but just generally about infection control. So we just need to think about that generally. And cost, I think, is going to be shared, between therapists now and then parents. Although, as I said earlier, for those who still have difficulties with modern technology, the cost may still remain the same, but they have to come to the center for for therapy. So basically, these are some of the things that we have found out, and I've learned from. Thank you.
Yeah, thank you very much, Nana. Medawasa pa. With that, we can start opening the discussion. Again, a reminder to please use the chat for questions. You can also just raise your hand and we can try and spot you, but there may be more people in the discussion than we have on the screen necessarily. Or you can raise your hand in the participant list, or you can type a message that you would like to say something, and then we will call upon you or bring your question into the discussion. So I'm going to start going through the chat, and the first question that I see from Rupa is, has anybody explored parental expectations or acceptance of the telemodels for speech? Is this just for the short term, or is there a long-term model that will develop for these teletherapy models? What do parents want? So maybe everybody likes not having to travel to the center anymore. And maybe that increases compliance for some people. Maybe we're losing patients. What is everybody's experience with that? Mirta, Nana, and Lakshmi, do you have thoughts? And also everybody's on mute, so you need to unmute yourselves when you want to contribute.
Can I quickly translate the question to Mirta?
Please, by all means, Karen.
Preguntan si los padres están aceptando esta idea de telemedicina y si creen que va a ser a corto plazo o utilidad a largo plazo.
¿Respondo al tiro?
Al tiro.
Sí, los padres lo ven como una opción positiva porque ellos tienen temor al COVID todavía, y como ven que esta modalidad ha sido efectiva en sus hijos, manteniéndose en casa, están dispuestos a usarla e incluso esperan que nosotros los contactemos y los videos que mandamos semanalmente. Entonces es una muy buena opción para ellos y la están aceptando muy bien.
So Mirta says that the parents are willing to participate through telemedicine. They feel that their family and their children are much more secure at home in this environment. And actually she's mentioning that the parents, they asked to be called and to be reached with this kind of tool.
But also I would like to add, Tim, that in Small Train we developed a way of an application on the phone for the parents to accept to give consent for the treatment, because we could not expect for them to sign the regular consenting form that all our partners all our patients have to sign. But now through the phone, they can do that. By pressing, they accept the treatment. So it's a really neat thing that it was developed. Application, I must say.
Yeah, Glendora has weighed in and said that we're grappling with the same issues here with the reopening of schools and the provision of services to most vulnerable students. So some parents are very accepting of the telemodels, but others not. So that's very individual. And I think that also harks back to something that Nana was mentioning in her talk, that we may also, as a downside of that, we may also see a bigger divide between haves and have-nots, because some parents have to go to work, cannot stay home with their children, and will not be able to support them, may not have the technology, while the parents that are a little bit more comfortable financially and that have access to more technology can then take bigger advantage of new opportunities for therapy. Anybody else would like to weigh in? Is this creating opportunities? Is it creating new divides in our patient groups?
At least in our situation, it is reverse. Our parents do not want to use the technology. Maybe sometimes it's because of child not cooperating at home with the parents. They're better with the professionals. So many of the parents wanted to come to the center. They don't want this technology to be used most of the time. It could be because they're not understanding most of the time with the technology. When I'm speaking something, the network is not clear or the material is not available at home. Whenever the mother says maybe the child is not able to follow it, only when the teacher says he's able to follow it. Whatever the reason may be, but in our situation, many of them wanted to come back to the center and to the original way of speech therapy rather than this telephone.
Yeah, so there is a preference for face-to-face contact in many cases. Sorry, since we just have you here, could I follow up on the hi-fi that you mentioned on one of your first slides? I didn't quite get what that was for. Just as are you still awake kind of way of checking in with them?
We had this habit. The moment anybody, even if we forget to say high five, the child will be ready with the hand. You know, I said something great. Every talk, every car they say correctly, they feel good and they got used to saying high five. So the same thing happened when we started teletherapy. They're raising their hand. I was like, what to do now? Okay, fine. On the screen, high five on the screen. We could do that, but it's nice to know how the child got adjusted to do two different situations. But still they're waiting for us touch, for our voices, our high fives and things like that.
Thank you.
If I can jump in and tell you that for me, that I oversee all the Spanish-speaking programs in South America for a small train for the Spanish-speaking countries, for me, has been a blessing. For our partners, have been a blessing. For our patients, have been a blessing, because we kept supporting it. And I've shared someone along the time, Mirta, there's a picture in which Mirta is providing speech care to a child that lives 550 kilometers from Santiago. And Chile, I mean, it's very well developed, but we have many rural areas. We have stories, beautiful stories of children who did not have access to speech care, that live in the Andes, in the jungle, in Peru, in Colombia. You know, it's been an amazing opportunity in which now we're expanding. I mentioned in the prior session that I was in, that from April to July, Small Train has provided over 11,000 consultations in telecare. Among them, lots of them are speech. It's amazing the impact that we're having in providing speech care to patients. Amazing. I'm very happy, and telehealth is here to stay, and we're going to continue to support those efforts.
Yeah, it's not going away. Midori and Gabriela, you're based in Brazil, kind of just around the corner. Do you have similar observations for the non-Spanish speaking parts of Latin America?
Hi. Well, in Brazil, we don't have Smile centers. We have many Smile train centers, and we have other centers. They are all trying to develop teletherapies. In my own experience, my own experience is with private patients, including some from other states. So I'm facing connection issues, but I agree with everybody that teletherapy came to stay, and most of parents, they are very much engaged because they don't have to go to the clinic. But I have an opposite situation with some of the parents, because some of them, they are very busy on their work and they prefer me to go there instead of they having to stay with their children, you know. So one of them, when are you coming back here? Because I was going to their home before the pandemic. But I'm just working on some solutions for Latin America too, because and I mean, I know that we only have the WhatsApp app for most of cases, but I'm focusing on training local people so that near future, they can help in a better way. So this is what I can say, you know. I'm focusing on training, yes.
Yeah, thank you, Midori. Thank you for that perspective. Manju Subramanian was adding that along with travel costs for people who travel from very far off places, their health can be much better because they don't catch infections while traveling. And some parents have suggested that the child is not tired during the sessions as they're not traveling. So that can be one of the upsides of this. Hidea has a question regarding managing instrumental assessments, especially of velopharyngeal and insufficiency or velopharyngeal dysfunction in the center. Also regarding perceptual assessments of speech, do you mostly use asynchronized models or do you do it in real time? So do you have the patient record test words and send the file to you, or do you try and do it while you can see them on the screen? So how does that work with especially the bandwidth issues that some people are experiencing? Opinions, answers, solutions?
It's Simone from Toronto. I think that with the populations that we're serving, we really need to be focusing on somewhat of a hybrid model. When we're in situations where telehealth is available, I think that's a great solution, and families have been very accepting of it and very appreciative. We have families from remote areas that may not have had access to clinicians with cleft expertise that are now able to access it. We can also then provide handoff to local therapists by having them involved in sessions and building capacity through training. So that's been a real positive side of the cleft, of the COVID situation. In terms of assessing VPI, nasendoscopy, I think that is really at this point on a moment by moment basis based on the bigger situation of what's happening in each of our areas related to cleft and public health recommendations. So having triage and a list of patients so that once we are able to start running, we can really move quickly into implementing those assessments.
Mm-hmm. Thank you, Simone, for weighing in. Specific to the articulation assessments, Manju Subramanian adds that they use asynchronized recordings of audio samples. So I guess recording on the phone, is that what you're doing, Manju?
Yes, I tell them to record on the phone, and I also tell them to record it using the microphone which they get, with the headphones. So that makes it much more clearer. We did a very informal kind of not a study as such, but something very informal, where we found that when they use the microphones, the quality is much better. So that's how I've been doing. So I tell them the distance that they have to keep the microphone, and the material is given to them beforehand. I send them personalized audio messages as to how it is to be done. And then they record it and send it to me. Then I analyze. I find that to be much easier than doing a synchronous one, because many times the internet creates a lot of issues for us.
And then, of course, there's the problem of the audio compression that we have when we use things like cell phones or so, right? Where the audio is degraded a little bit. Yeah. Has anybody experimented with online softwares such as the WASP speech analysis, or I don't know? I can send a link for that maybe, just as something else to play with. So asynchronous assessment of articulation, that makes sense. Nana wanted to add something a little earlier. So her point was that we're going to find the two models working side by side, telehealth and face-to-face, like also Midori was saying from Brazil. Some parents can afford and who are now working from home will want to use the new technology. Those who are more likely to want to come to the center, especially if they're supported by Smile Train, for transport and meals will prefer to keep doing that. Malka is saying that they use instrumental evaluation for VPI for endoscopy, for LVFC. What is LVFC and FOL, if necessary, in Sri Lanka? Malka, could you tell us what those acronyms are? LVFC and FOL. Maybe I'm the only one not knowing them. Malka? No. Okay.
Probably it's like lateral video fluoroscopy. The other one I don't know.
Yeah.
That makes sense. Lateral video fluoroscopy, but
Lateral video fluoroscopy and FOL. Okay.
Can I step in, Tim?
Yes, please.
It's me, Karen. Debbie's had, she made us a course a few weeks ago about also something similar to what Mirta presented in addressing and having tools for speech therapy. And in that discussion, I felt it was important, as I feel that it's important again, to mention that it's good telehealth will stay here. It's come to stay. We'll have access to children that are further away or they can't afford to come to the centers, or where centers don't have speech language therapists. So I have nothing to say for it. It's a great tool. It's something that COVID has given us as a gift. But on the other hand, I feel it's important to mention that evaluation, screening, diagnosis has to be face-to-face. So we cannot rely only on telemedicine. We have to search when it comes. I know now that we are now in a very acute situation of COVID, but when it comes and when the time comes, we have to keep in mind that we are therapists and we have to have the patient and the family and the team face to face to have a good treatment and to have then good results. We cannot rely only in telemedicine for everything. So I feel it's like a woe that we have this tool and that we are all experiencing it. It's like a Christmas gift for a child, but keep in mind a Christmas gift is sometimes only used a week, a month. And with those excitement, we don't have to lose that in mind that we are, again, face-to-face therapists. I just wanted to say that.
Okay, thank you for adding that, Karen. And indeed, the discussion finds positive, negative aspects. Carolina Rivera says that my patients love the telerehab and I have great results. Sonakshi Raval points out that the session online can be recorded and analyzed later. So you can show parents, for example, before and after. Anjali Kant also finds parents and children accepting the telemodel and to be quite excited, and then also using asynchronized therapy, I guess, when the connection isn't so good. But Aparna says that regarding anything such as velopharyngeal dysfunction, telehealth can be tricky, so it might be a better idea to recall the patients to the center. And Anjali Kant again agrees with that. So Glendora is pointing out, we've had telehealth for a number of years, at least in high-income countries. It's nothing new. But now we're really forced to make much better use of it than we have done before. A couple of patients have also said that they were able to find patients again and to rope them in that had been lost to follow-up, so that they were able to reconnect with patients and now provide therapy to patients that otherwise had fallen off the roster. Sorry, this is a long chat now, and I'm trying to get through it and summarize as best as I can. Karen made a remark that we have to be face-to-face with family and patients, and that reminded me of a question that Nana had previously said about hard of hearing patients, deaf patients, who rely very much, and I guess in speech therapy, you also rely on the patient seeing your face. So how does that work with masks? I know that the speech therapy students in our department are getting masks with little transparent windows around the mouth to make sure that the other person can see what they're saying. What has everybody's experience been in that regard, the visible aspect of speech, the face-to-face aspect?
It's funny, this is Glendora, it's funny, Tim, that you mentioned that, because I was looking at that. I oversee a speech language department, related service providers and special ed. And so they, I found, it was from Ontario, correct, that you're talking about, those graduate students? Correct. I donated, but I couldn't get masks for them. They were overwhelmed, but I do have masks.
Oh, okay.
So it's helpful, they can see, but your mouth, your sound is still muffled. So, I mean, you know, it's not the end all be all, but at the very least, we can have that interaction, that connection with the students that is so missed when you know, block half of your face.
Mm-hmm. And are those masks washable, or do they go into the garbage?
These are supposed to be washable.
Oh, good.
I mean, right now I'm doing everything online, so I haven't used mine, but I've gifted it to my speech therapist for when they go in person, they will be able to use them.
Okay, thank you. Has anybody else experienced with the see-through masks?
Yes, we have used them. Mirta tells me to say you something. He has been using it, and he has the feeling that it's difficult also because of the muffling and the vision with the flow, with the airflow, gets bluffy, and also her voice has to be louder, and he has, after the treatment, then voice disorders and voice problems.
Sore throat.
Not good for a speech language therapist.
That's hilarious.
If we are a role model.
But I guess, I mean, taking the, again, moments of challenges make us be more creative. And going back to telehealth, I guess it's helping take care of patients that could not be able, that without it, we couldn't reach to them. And it's not the only solution. It's the solution in the meantime for many of our countries. And yes, I definitely agree that some evaluations need to be done in person, definitely. But I mean, time being, I guess it's a great resource. And also what we're focusing is in training our speech pathologists. And maybe Karen can mention a little bit more about being more rigorous in terms of training providers. So
yeah, Karen has just geared up, I see.
I'm a model now. I'm using this.
I know.
So it's also easy and light, but then again, it's open here. So you have to wear the mask. So it's difficult.
Yeah. Debbie, you were saying that there's a lot of need for training of therapists how to do their teletherapy well, especially in private practice, right?
I'm just speaking on behalf of therapists in the UK, and there's an active group of therapists who only work in independent practice, so across the board of speech and language therapy. So when COVID happened, all of their work is independent, and therefore they had to move into telehealth pretty quickly because it was their livelihood and the way of them earning money. And as a result, though, there's some fantastic expertise in using PowerPoint, using some interactive games that have been developed. In Speech at Home, we're using low-tech stuff actually, but so I think that it's interesting because there are areas of real expertise in how to maximize telehealth. I think going back to what Karen said, actually it isn't that every child is appropriate for telehealth in terms of, say, my own experience is improving articulation in cleft, and you have to select the child and the family. We had some criteria for which ones we were using, going to go forward with the program. We have 6 therapists at the moment using speech at home. They're doing a quality improvement project, which we will hopefully be reporting later in the year, Trina Sweeney and myself. And it's really interesting because it isn't that we're finding that they're able to use the programs and resources in the main. The majority of them are doing well with their families, and families are accepting it. And 1 or 2 are working with teaching assistants in schools now. So we're sort of building our experience of telehealth, but I think it's here to stay, and we have to keep that door open. And certainly in the whole digital, having just come from leveraging technology and looking at a little bit of that in the broader sense, it's there, and we need to just carry on developing our expertise and knowing the best patients to use it with. But equally, we know that there is a large number of patients in lower middle income countries that can't get this help because of connectivity and bandwidth and devices and so much complexity. And these are the ones we should be also thinking about as well in this discussion. And I don't know if we can open it up to those children now. Siraj, you would have some experience of this, I'm sure.
And Siraj, you also made the point that it's the training of facilitators that is something very important for the success in the teletherapy. Would you like to comment more?
Yeah, hi Tim.
Hey.
Yeah, I think we are working with families, who really don't know how to provide therapy at the other end. So I think the first few sessions will go on talking to them and preparing them for the session. So especially with the younger children, if you think they will readily come and sit in front of you and talk to you, I think it is a good thinking to start therapy session. But I really don't think that is very much possible. An adult patient may be readily, to start a therapy session, but not a child less than 10-year-old. So facilitated training program is very important, because I see that from my own experience when my daughter sits for the online school. The moment the power goes off, the Wi-Fi gets on, they get so anxious, what happened, and to bring them back to the session and to have the session restarted, it is very difficult. And then, to be able to give that kind of a reinforcement, all of that, children needs to be really sharp, and an adult is always required to pick up those small reinforcement which the therapist is giving, and then to be able to get in that course correction period. I think facilitated training program is very important, and a check after 7 or 8 sessions to see whether a child is really benefiting from teletherapy is very important. For that, you can discharge the child or move from an online program to a store and forward method, where an empowered person can directly provide, and you can only watch the video recordings and give feedback. So teletherapy is not one size fits all. There are so many problems in it, and I'm talking from my own experience of resource limited region, and there are my other colleagues who are there in India. So it's not all green everywhere. So we really do need to we not only have problem of the network, we do not have the technology at home in every house, and when it is available, I may not be available. So these are all something which we are struggling to find answers. So hopefully we will be able to meet. Right now education has taken priority, so children are using smartphones and tabs for daily school. Speech therapy comes after schooling, so we need to see where we fit in.
Yeah, good points. So Ariana reminds me to also ask for non-chat related questions that somebody might want to ask, because I have not actually watched for hands being raised. Otherwise I'll keep going through the chat, but if somebody would like to
I will speak on behalf of Mirta.
Yes, please.
She wanted to add that with this video tools, she felt that the children can see it one and again and again and again. Sometimes in the sessions you have only the 30 minutes or the 40 minutes sessions one-to-one. But with this, the children, they keep tracking and reviewing their videos and the speech language therapist model once and again and again. So this has been very helpful. And she's also adding me that as a therapist, you have to be funny and engaging the children as you do it in one-to-one. So if you have nice videos and that are there with lots of colors and they have jokes in it, the children, they want to see it every time more. So that's what she wants to add.
So and also in a live session, there's sometimes little icebreaker activities or little play activities. How does everybody find that working in teletherapy?
Myself, I'm talking too much now.
No.
I feel very difficult. And with smaller children, I always ask the parents to stay. And that's very difficult because most of my parents, they do work as well from home. So you have to find the timing, the right time to have the parents or an other adult. It hasn't to be the father or the mother. It can be a grandmother. I don't know now in the COVID era with the adults. But I always rely on a co-therapist with smaller children. With children 11, 12 years old, and from that on, they're used to these tools, so it's easier, and you don't need the games. But with the smaller children, it's a huge effort, and I have to say, it's difficult, and that I have to prepare myself much more in advance for smaller children than for teens or preschool children.
Yeah.
And if you, Pam Sharon from Small Train shared the link to the videos. Mirta and her team prepare really funny videos. So those videos are engaging for children. That was an effort precisely that we assessed to work like an early stimulation. So that's why we worked this project with our, as I call them, my dream team of GANs, and also Karen, that it's adapted to GANs in this way, but they're both all work together, GANs and Calvo McKenna. So that was a great effort to develop those. How many videos there are, Karen? 50 something, no, Mirta, 52? 55? No te escucho.
55.
Más de 50, sí.
More than 55 videos. So I encourage you to look into that library that Pam just shared. It's a great tool for parents. And of course, I mean, we need the assessment of a professional, but the initiative was to take care of the younger children at home and to help provide early stimulation in that sense. So
wonderful, and I think it will help the rest of us with our Spanish too.
Seguro que sí.
Nana, you had your hand up. Let's hope for good internet in Ghana.
Can you hear me now?
Yes.
You can, okay. Yes, I just wanted to add to what Karen was saying, that when they are little ones, we have found that truly appreciate the work that the speech therapist does with the children. Because we had parents who, after maybe 3 sessions, realized the efforts and how much fun, how much animated they needed to be, and how they needed to be able to play with the child, and the games they had to invent to be able to keep the child still, in therapy. So it's made a lot of difference, I think, for some. It makes a lot of difference for some parents, and in that natural and everyday interaction with their children, they will have a better understanding of what we mean when we say they need to be animated, they need to talk to children in a relaxed way, and to have fun, to play with the children. So I think it's a way of also training and supporting parents to learn how to interact with their children on a daily basis. So the teletherapy has helped do that, because initially we saw some of the videos. If you saw some of the videos of the parents, the mom and the dad, in fact, the mom and the dad started it together. And it was really a challenge for them trying to get their son to sit for a few minutes. By the third session, they were doing so well, and they started commending themselves and patting themselves on the back for the work that they had done. So I think it's also a way of educating parents and helping parents to understand what goes into helping the child.
Yeah. Maria del Carmen, you have your hand up too.
I'd like to interrupt quickly. We have just 2 minutes left, so if we could start wrapping up, Tim, we can have one more speaker.
Okay, I'll say
So
it quickly.
you have the last word, Maria.
Yes, I just wanted to say that we are also working with earlier stimulation programs where the kids work with their parents since, 10 months of age, and it's working great. We have to put some hands-on activities, but I think it's great opportunity for parents to learn how to play with the kids. Just wanted to say that.
Definitely, yes, yes. So it's something that can benefit the parents as well. So since we're out of time now, the hour really passed very, very quickly, I find. I'm not even going to attempt to wrap this up because we went into so many different directions with the discussion, which I think was necessary to do and was valuable to do. So I don't really have a great summary here at the end, but I would like to thank everybody for attending the session, for participating, and for providing very different perspectives from around the world, from different social structures, different societies, different countries and nations, different languages, and cultural backgrounds. So I think it was really nice to have this kind of overview, and hopefully it was a little bit inspiring for everybody to hear what everybody else is doing. Please do read the chat. I think it will be archived and maybe accessible later. And I think we have also recorded the session. The session is recording, so we'll be able to go back to this later. Thank you very much. And Ariana, it's probably my job to close the session now, right? Or it's your job because you're the host.
I'll do it. Thank you everyone for joining. We will break now before the closing plenary. Looking back, moving forward, it's scheduled to start in 5 minutes, so we'll see you there. Have a great rest of your day.